Hello, my name is Dr. Stephanie Lay. I am the Assistant Medical Director at the New Jewish Home, which is a 500-bed skilled nursing facility in Manhattan on the Upper West Side. I also work as a clinical assistant professor in geriatrics and palliative medicine, and I'm part of the Department of Hospital Medicine at Mount Sinai Hospital. So today's topic will be geriatrics and palliative care in the nursing home setting. I have no disclosures. So our objectives today will be, one, to recognize the need for geriatrics and palliative care in nursing home populations. Two, to understand some basic symptom management principles and how to apply them in a nursing home setting. Three, how to involve your nursing home care team in a palliative approach to care. Four, understand basic advanced directive documents and why they're important. And five, to describe hospice in the nursing home setting. So starting off, what is geriatrics? From the American Geriatrics Society, the definition is that geriatrics is the specialty focused on the high quality, person-centered care we all need as we age. And these are some common geriatric syndromes that are much more frequently seen in older adults and make this kind of a unique specialty. So having worked in a nursing home for 4 years now, I spent a little time reflecting before this lecture about how it's different in a nursing home to practice geriatrics. And I would say one of the biggest things that stands out to me is just the focus on federal regulations and quality goals that overlap with clinical care concerns, of course, but are just very a different focus than what you might think about in a clinic or in a hospital. So this is not an exhaustive list by any means, but I spend a lot more time thinking about pressure injuries, about how we can manage falls from a non-clinical perspective, about infection control, about the use of restraints, specifically the not use of restraints in a nursing home, the use of psychotropics and how to monitor those, and rehospitalizations, many other things that are really specific focus and affect the nursing home overall in terms of quality measures and how we can perform as a facility. And another thing that I really love about nursing home care is that it is really highly interdisciplinary. So you work with very tightly knit teams all the time to provide care to the people who live there and the people who come for rehab as well. So palliative care. What is palliative care? So this definition is from the Center to Advance Palliative Care, or CAPC, and this is really general, but I think correct, and specialized care for people with serious illness. And that means people like not just at the end of life. So my reflections on being a palliative care physician in a nursing home setting is that really everyone benefits from palliative care, whether they're there for subacute rehab or SAR or long-term care. Really, people have serious illnesses. That's how they ended up in the hospital. That's how they ended up coming to a nursing home or a rehabilitation center. So it's really a good place to practice palliative care, no matter which side of it you're working on. The interdisciplinary team, once again, a really big feature of nursing homes. You work with many members of your team all the time on all aspects of care, and they and you together are really what makes a nursing home run and what makes the care high quality. There's a lot of education that I have to do for patients and families and staff regarding palliative care. And there's a lot of discomfort about end-of-life care. I think there's maybe less exposure. People don't always know like what is to be expected. And that includes the staff, because they are the people who are taking care of these patients. And so it's really, really important to include them in conversations so that they know what's going on, why are these choices being made, that this is in fact aligned with the patient and their family's goals, and that they are included in doing the best that they can to provide palliative care for people at the end of their lives or not at the end of their lives. So let's talk a little bit about nursing home population to get a sense of who's here. So this applies more to the long-term care in terms of people living in nursing homes, but as of a 2020 survey, there are about 1.3 million people living in about 15,000 nursing homes across the country. So some of the demographic statistics might be surprising because when you think about nursing homes, you think older people. And it's true that 82% are over 65, but actually only 33% are over 85. So the oldest old is maybe a smaller population than many of us might have thought when first considering like, well, who is in a nursing home? So there are significantly a number of people who are in their 60s and 70s. And also only 46% have an actual diagnosis of dementia in this survey. So there are people who are in nursing homes for other reasons. They have other physical impairments, they've had strokes, they have other types of cognitive impairment, they're unable to care for themselves and don't have social support. So it's a more diverse population than you might expect when you first think, oh, who's in a nursing home? And as I mentioned, there are two sides to a nursing home. So there's the skilled nursing facility, subacute rehab or post-acute care component. You'll hear different names for it. And so those are people who are not residing at the nursing home. And then there's the custodial care component, which is the long-term care, the more stereotypical vision of a nursing home population. So when thinking about palliative care and geriatrics in the nursing home, how do you know if somebody might be eligible or might benefit from palliative care? And while I did mention that palliative care is not just for end of life, a lot of people in nursing homes, it turns out, may be end of life. And there has been a really interesting, simple and validated question you can ask called the surprise question. So they asked clinicians, would you be surprised if this patient died in the next 6 to 12 months? And essentially just got their gut reaction. And when they validated the answers to the actual prognosis, it was extremely accurate. So trust your gut and ask yourself the surprise question. And it bears out in the data as well that in long-term cares across the country, the average length of stay is 5 months, which is under the 6 months that's typical for hospice end of life definition. And by length of stay, I mean, how do people leave nursing homes when they're in long-term care? Usually they die. This is the final place where they're living. So a lot of people do not live very long once they enroll and come to live in a nursing home. So I did a little reflection because as a geriatrician and a palliative care doctor, I feel like there's a lot of overlap between the two specialties. And I just put together this Venn diagram out of my own reflections. It's by no means comprehensive, but as you can see in the middle, the things that are overlapping between the two specialties, there's a lot. There's goals of care, there's end of life, there's symptom management, deprescribing, hospice care, working with interdisciplinary teams, dealing with people with chronic illness. So, the takeaway point from here is that a nursing home is a really great place to practice both. I feel like I get to use my geriatrics and my palliative care skills together in a very integrated way all the time. To help us think a little bit more about the need for geriatrics and palliative care and the overlap, I have a case for you to think about. Now, this is an 87-year-old man with a history of COPD, on oxygen, with coronary artery disease, high blood pressure, enlarged prostate, with urinary retention and a Foley. He has 2 pressure ulcers. He is severely underweight, and from a functional standpoint, he can talk, but he hasn't walked in a long time. He's pretty much bedbound. So, if you think for a second, where might I have seen this patient? Is this on my long-term care? Is this on my post-acute or subacute side? And the answer is it could be either side. Easily, this could be somebody who lives on my long-term care unit. Easily also could be somebody who came to me from the hospital. So regardless of which side of the nursing home this person lives on, he has a lot of clear signs of serious illness and a need for both geriatric care think of a lot of geriatric syndromes. Like this person may have risk of frailty, falls, he might have polypharmacy with his multiple comorbidities, and then many palliative needs. Does he need advanced care planning? Does he need pain management, symptom management? So this person needs both. He needs both geriatrics and palliative care. And that's really, really common in the people you will find in a nursing home. So as we're talking about nursing home care and palliative care, it's important to think about dying in the nursing home. So about a quarter of all US deaths actually do take place in a SNF or a skilled nursing facility. And for people over age 85, going to a nursing home, either for rehab or long-term care, a significant number of them do, 40%. And there's some estimates that by 2030, almost half of all Americans age 85 and older will end up living in nursing homes and possibly dying in nursing homes. So when you speak about dying and end of life in a nursing home setting, you have to think about what is that like? What is the quality and what happens to these people? And unfortunately, hospitalization is fairly common. So even just thinking of people who are not necessarily end of life, if you look nationally, hospitalizations are very common for people who are discharged to rehab. Over 25% of those people within 30 days go back to the hospital. For long-term care residents, that number is also high, a little bit lower, but 17.4% of long-term care residents are hospitalized annually. So nursing home residents transferred to hospitals, is that appropriate for them? Maybe not. Sometimes they do receive care that's not within their goals, might be more aggressive. And so we really have to think, like, is this the right thing to do for this population? Are there ways to prevent that? And many nursing home residents do die in the hospital, which, generally, if you ask somebody where they'd like to die, usually it's not in the hospital. So we should think, is this trend, is this the right thing to do? So having learned about the likely prognosis for people who are, especially people in long-term care, learning about nursing home populations, you can see that there is a palliative need. They are often very impaired. That's how they ended up from a functional standpoint in a nursing home. They have more than one impairment in their ADLs, 80% of people do. And at least 60% have some sort of cognitive impairment, whether it's dementia or from another reason. And from a symptom perspective, it's been found in one study at least that the last 5 days of life, many people report pain, 12.2% moderate to severe and 22% mild. So there's a lot of pain management, symptom management as well that is inherent to having a frail, sick, chronically ill population, some of whom are at the end of their lives. But given that there's a great need for palliative care, what are the barriers? Why don't we have it more? There are a couple issues, I would say, and there's many more than just these, but some of the big ones that I've noticed are systems issues. So you have a lack of providers who are skilled in palliative care just across the country. We need to train more palliative care doctors or people getting more training in addition to their regular specialties. And there's also kind of a focus on maintaining function because of some regulations in nursing homes. People who lose weight or decline, that could be working against the nursing home's statistics. And so it might detract from the interest in rethinking, like, well, actually, is this person expected to decline? Do they have cancer that's end stage? Do they have an end stage dementia? But there are exceptions. So if people are recognized to be end of life, you can actually improve your numbers by noting that, by enrolling in hospice, by documenting their end of life status. You can kind of get a break on some of these statistics. And then finally, there's insurance issues. So insurance coverage for hospice differs from the insurance cover for rehab. So that is a conflict, usually not a problem for the long-term care residents. But just thinking about if you are a very sick person on subacute rehab, and you actually would like comfort care, would like hospice care, you have to think about the kind of insurance implications there. Also, reimbursements for hospice patients can affect whether a facility chooses to have hospice care at all at their facility. As I found out when I was trying to discharge somebody from the hospital recently, their facility that they were trying to go back to did not have hospice as a possibility, which was surprising to me. So Jewish Home is very much, where I work, very much aligned with palliative care and hospice care. And we absolutely do provide hospice care, but that may not be the case everywhere. But what are the benefits to having palliative care, like in the studies? So there was a study done in nursing homes in 4 states that had introduced palliative care consultation, and they found a significant reduction in hospitalization in the last 30 days of life. There was some decrease in readmissions in general, and they had a significant impact, especially if they occurred further from the death, so more upstream, identifying people early. And there was an increase in hospice selection and a reduced pain reporting, or reduced pain levels, I would say, and improved family satisfaction as well. So there's significant benefits to having palliative care involved in your nursing home population. Okay, so in summary, there is a need for nursing home patients to have both geriatrics and palliative care. As we talked about, the demographics support this. It's an older and frail population. They have really high risk of going to the hospital. Many of them potentially are at the end of their lives, and there are improvements in outcomes with palliative care. And of course, geriatrics is key. I do feel like it's more intuitive. Many people are like, of course, geriatrics in the nursing home. But palliative care also really, I think, indispensable in a nursing home. So moving on to our next objective, which is to talk about symptom management. So looking at specifically end of life, this graph shows the prevalence of symptoms here on the x-axis and the percentage of symptoms reported at the end of life. And you can see that dyspnea, pain, noisy breathing, and delirium and dysphagia, these are really big ones that really affect quality of life in nursing home populations and people at the end of their life. And so one of the things that makes nursing home, I think, very unique is how important it is to work with your team to implement all these things. So I'm going to try and focus a little bit more on the non-medical side. We'll talk about kind of some standard practices in medicine, but also how you can work with your whole team to bring a palliative approach to patients who live in the nursing home or who are in rehab as well. So on your front line of people providing direct care every day to your patients, and these are the people who are going to know your patients and their families the best. It's your CNAs or certified nursing assistants, your RNs or LPNs, your nursing staff. These are the people who really provide like moment-to-moment care and really see all of the symptoms, know all of the distress that the family is having. And so it's important to keep them in the loop as well to help them understand, like, okay, this person is actually very ill. They have chosen for comfort care, and this is the reason. Because it can be really distressing to your staff if they're providing care, but they don't really understand what the goal is or why. There have been times like I have gotten questions from nurses about like, well, why are we giving this morphine? Like, are we actually killing this person? And so I can't even imagine like how distressing that would be to think that you are being responsible for, harming the patients you're trying to take care of. So I spend a lot of time educating my staff whenever somebody elects for comfort care or, what have you, about like, here's why we're doing this. And here's why, this is in line with their goals. And you can definitely get a lot of information from the aides and the nurses as well about how the families are doing, any like concerns they seem to have. It's really, really important to have them involved. And there's plenty of other support from other interdisciplinary members, the social workers. They do a lot of like care planning, coordination, and funeral coordinations. TR is therapeutic recreation, so lots of non-pharmacological support, music therapy, pet therapy, companions. The dietitians and speech pathologists are really important because nutrition at the end of life is always a big issue we'll talk about a bit more. Your pharmacy can help you out figuring out the medications that are available and that can be given. Chaplaincy is very important to provide spiritual support at the end of life, and more. You know, a lot of team members working with you in the nursing home. The first symptom to tackle was the most prevalent, as we saw previously, is dyspnea. And so, of course, you want to do your usual medical evaluation. And I want to mention a bit about treatments. So in a nursing home setting, kind of unlike a hospital setting, your opioid management might be mostly oral. IV routes are not as common in a nursing home. It's just much harder to do with the nursing staff and all of that. You can think about maybe fentanyl patches as well, but just keep that in mind. And then there's the non-pharmacologic fans and positioning. Again, a reason to involve your staff, like about making sure people are upright if they're having COPD or CHF, positioning the fan in front of them, and whether or not they should have oxygen. And oxygen really hasn't borne out to be helpful unless people are hypoxic. And a big thing is like they'll take off their oxygen, and staff will be very distressed about this. And you have to educate the family, the staff, the patient, like it's okay. It's okay if the oxygen is not making you comfortable. We can do other things. We don't have to force you to wear the oxygen. Another issue around breathing at the end of life that is really distressing for people is what's called the death rattle or terminal secretions. And here again is really education about what this means, whether this patient is actually experiencing the distress. Usually it's more distressing to the people hearing the condition, and about positioning and other non-pharmacologic measures. And then things that I've used in the facilities are the sublingual atropine drops and scopolamine patches. Again, IV routes are less commonly used for medication management. Pain was the second big symptom, very common. And pain reporting in the nursing home is mandatory. So any nursing homes that receive federal funding have to report the percentage of residents with pain in something called the minimum data set. So that's really an important issue already for nursing homes. And this is not just end of life, but just overall. It's estimated that about 37% of nursing home residents do experience pain. So something to focus on. But how do you assess pain in someone with dementia, right? A significant population in a nursing home has dementia. And so there are nonverbal pain scales. The one that we use in our facility is called the pain AD. And it basically uses things that the patient is exhibiting, such as grimacing or guarding or agitation or appetite. So there are nonverbal cues that you can use to figure out whether someone might be having pain. And so how do we manage the pain? Again, there's an emphasis here on non-pharmacologic strategies, such as your therapeutic recreation, for music therapy, nurses and aides for positioning. The use of medications should include the non-opioids as well, and targeting the specific kind of pain. We also have physiatrists at our facility, so you could think about whether injections might be helpful if it's a severe joint pain. Opioids, of course, play into the picture if needed. And then one thing to also really think about in a nursing home setting is whether you schedule your pain medication or have it as needed or both. Just in large part because the realities of staffing and also a highly cognitively impaired population. So the ratio of nurses to patients or residents is going to be very different than in the hospital, and would be different as well from someone at home who kind of is one-to-one with their family member. So they may not be able to ask 38 patients in a timely manner, like, oh, do you have pain right now? And of the 38, maybe half of them or more can't even tell you verbally. So if you expect somebody to have constant pain, you may want to consider scheduling the pain medication to guarantee that they receive some coverage. Eating and swallowing are very big issues. Families, rightly, are very concerned about their loved ones being able to eat. It's one of the ways that people show that they love and care about them. And people at the end of their lives and in a nursing home often experience these issues with eating, trouble swallowing. So in a nursing home, you do have speech and language pathology who can do assessments and kind of help you with food consistencies. And they can also help with family education. But also it's up to the physicians and other clinicians to talk about, well, what is going on? Is this part of their chronic illness process? What can we expect? And for the staff, knowing who needs to be fed carefully by hand is also very important for them. So you will be asked about artificial nutrition by your families if you work in a nursing home at some point. And the key thing to take away from this is that there's just not been benefit shown in studies for artificial nutrition and hydration at the end of life. So once again, you have to speak to the families, speak to the staff. I get a lot of questions about, well, are we starving them? Why shouldn't we put a feeding tube? Should we get IV fluids? And you have to talk to them about what a feeding tube means and whether it's beneficial in their particular medical condition. Because there are a lot of negative downsides to feeding tubes that a lot of people don't think about, such as infections, continued aspiration. It does not prevent aspiration. And also the need for tube replacement, which might necessitate a hospital transfer, which could be problematic or distressing to a resident. And just, it's not indicated at the end of life. If their terminal condition is really what's causing them to die, it's not going to be reversed by a feeding tube. So other things that may be asked of you are, appetite stimulants, different food supplements, and there's some evidence around it, but not much that it makes a big difference. Delirium is a big symptom in nursing home patients and those at end of life, and it, I think, is under-recognized. And so it's important if this is causing distress or potential harm for the patient, they're really agitated, they might fall and get out of bed, you might need to use medications. Of course, you want to focus on non-pharmacologic interventions as much as possible. And here it's important to educate your family and your staff about that this is delirium and that this is why people are behaving this way, and to think about, are there mechanisms to put in place to reduce potential harm, closer monitoring by the nurses, making sure that all the fall prevention things are in place. These are some things to think about in nursing homes in particular. Fever is pretty standard treatment. You can treat with medications. You can also do these non-pharmacologic interventions. And then infections are something that also are going to be discussed with your goals of care, because in an end-of-life population, and for those with advanced dementia is one that I deal with a lot, is it really the right thing to do to treat all infections? And maybe it's not, because they're having these recurrent aspirations that are due to their end-of-life condition. And you can offer, instead of repeatedly giving antibiotics, just managing their symptoms of fever or dyspnea. If you know that this is part of the dying process, this is part of their end-stage disease and not a simple infection that can be treated and then will continue with their regular lives. So there are things to offer instead. And a quick mention on polypharmacy, which is a geriatrics thing typically, but in the palliative setting also I think is important because at the end of life, it's important to deprescribe. For all of geriatrics and all of medicine, in my opinion, it's also important to deprescribe. And so think about the prognosis of your patient and whether they're actually still benefiting from this medication. Are they benefiting from their statin if their prognosis is six months or less? Probably not. So each and every medication, take a close look. Think about whether they still need them. So this is a bit of a summary of the non-pharmacologic things of palliative medicine, training your staff, engaging with the patients, discussing goals of care and what makes a person comfortable, kind of knowing the patients really well, and then working with your teams. Care planning is a big thing in nursing homes. Meeting with the team, coming up with a plan of care, putting it in place to achieve comfort. So what are some other practical ways to bring palliative care into your nursing home? One is to have a consultant who actually does palliative care. One is to have expertise within your staff, so people who are palliative care trained in some way or get additional training. And another is to have hospice care coming into your facility. So in summary, for symptoms, some of the most common ones that you will see are dyspnea, pain, delirium, and dysphagia. And education is really important for families, for staff. And along with general management principles, there's some unique factors that go into the nursing home, mostly the really heavy involvement of the interdisciplinary team. So communication is key, care planning is key, and taking advantage of every one of your team members' expertise. Moving on to advanced directives and why they're important. So there are many older adults without family or friends or any support. A lot of them end up in the nursing home partially for that reason. And so advanced care planning before they lose capacity is crucial. Because once they do, there's nobody else who can kind of make the substituted judgment. It becomes medical decision-making, and you lose the opportunity to really do what this person would have wanted for themselves. So most. So in the state of New York, anyway, this is how we order advanced directives. It's called Medical Orders for Life-Sustaining Treatment. Other states have different names, but it's the same idea. These are orders, and they are supposed to follow the patient no matter where they go. Doesn't matter if inpatient, outpatient, et cetera. And filling out a MOLST really involves more than just like checking boxes. It really is a careful goals conversation, drawing out the values of a person and then using your medical expertise to help them decide, what is most in line with their values. And in New York State, there is a lot of guidance about how to do this process based on the varying levels of capacity for decision-making that exist. So in our state, we would look through these various checklists, make sure we're doing it correctly. Healthcare proxies are also very important. It's kind of the next best thing to being able to ask patients themselves. The biggest things is that patients have to assign them. Families cannot assign themselves as healthcare proxies. It's one of the big downfalls I've encountered when educating people about these forms. So another thing to do early when someone still has the capacity to assign. Although capacity is decision specific, so the threshold for deciding about whether you can assign a healthcare proxy is not that high. It's different than your capacity to understand the implications of complex surgery potentially, or other big decisions. The capacity for healthcare proxy is simply, who do you want to help you make medical decisions? And so the fact that someone has dementia or a mental illness doesn't necessarily mean they don't have capacity to assign a proxy. And as a physician, you can really assess capacity for this kind of issue. You just have to be able to see that the patient is able to express a wish, to explain it, to be consistent. Just a very simple capacity assessment. Another document that you'll run into is a living will. And while it's nice because it does lay out generally what people want, I usually find them to be somewhat vague, and there's just no way that one document can cover every possible medical scenario. So it's important, even if someone has a living will, to have discussions with them about their goals. So in summary, for advanced directives, it's important to understand the different types of advanced directives and what they're used for, why they're important. And it's also important to have these discussions with patients early when they have capacity and can tell you what they want. It's also important to make sure that even if you're discussing with the patient with capacity, that people who might be involved in their lives and in their care also know about the decisions that are being made. You wouldn't want for a patient to make a decision to be, do not resuscitate, and then their family doesn't know, and then when the event happens, they say, well, this was never discussed with us. So also really important to involve any people who are important to the patient's care as well, with their permission. I'll move on now to hospice care. What is hospice? It's a Medicare benefit, and generally for those at the end of life, less than 6 months, kind of by any reasonable guess by a clinician, and will provide additional layers of support no matter where you are. So it's at home, in a nursing home, wherever it is that you live. They'll provide an aide, a nurse that visits occasionally, a doctor who will be available for some consultation, chaplains, social work, and bereavement services. A big important thing to know in nursing homes is who would qualify for hospice who has dementia, because that's going to be a big population. So if you look at a scale called the FAST, which is a dementia scale based on functionality, once you reach the level of 7C, you're non-ambulatory, among other things. Once you reach that level, you also have to have signs of end-stage disease, because dementia can be really hard to predict. People can plateau and be kind of stably very ill for a long period of time. These secondary criteria tend to suggest that things are really progressing to the end. Those include aspiration pneumonia, pressure ulcers, weight loss, recurrent infections. What happens if you enroll someone in hospice and then they, quote unquote, graduate or disenrolled? And this is because maybe they haven't declined fast enough. Like I said, dementia is really hard to predict, but that's okay. You can still treat somebody with palliative intent in a nursing home setting without a hospice team. It's all the things we talked about before. So in summary, for hospice, it's a Medicare service at end of life and can in fact be given in nursing home settings. Quickly to mention that you can bill for your palliative care. You can use regular E&M coding, just regular nursing home codes for visits. You can also bill for advanced care planning. So the codes for the first 30 minutes and then the codes for the additional 30 minutes, it has to be the majority of, or greater than half of, so 15 or 16 minutes or more for the first 30 minutes. And each additional 30 minutes has to be greater than half of the 30 minutes to be added on. And it doesn't have to be a doctor, it can be non-physician practitioners as well who can bill for this. And you can bill for this as many times as you need to, as many times as you're discussing the goals of care. So to start wrapping up, so where do we need to go in the future? In my opinion, I think we need to recognize the need for palliative care and increase the ability to have access and to pay for these services. Nursing homes can invest in other programs, such as something called Comfort Matters or other programs that focus on care for older people and comfort care. And my main takeaway points are that many individuals in nursing homes would benefit from palliative care with or without hospice. Also, certainly would benefit from geriatrics care. Symptom management at the end of life is important for quality of life. An interdisciplinary team approach is essential to all care in nursing home settings. And it's important to address advanced directives for all patients. Thank you.